Hello everyone. So today we look at antepartum hemorrhage, which is an obstetric condition, which means pregnancy related, and there are many forms of antepartum hemorrhage, but we'll focus on placenta previa for today. So as usual, these are the objectives. We'll define what APH is. We'll look at some of the causes of APH, and then we'll focus on previa. So the definition, the risk factors of previa, the clinical manifestation, the classification and its significance in management, investigations, the degrees, stallworthy sign, which is, I'll look at it in detail. It's one of the manifestation of a specific type of placenta previa, and then we look at a quick look at the management. So definition, antepartum hemorrhage. Partum usually is pregnancy and delivery related. Anti means before delivery. So antepartum hemorrhage means bleeding into or from the genital tract after 28 weeks of gestation. The reason we go for 28 weeks is because most of the countries, including Kenya, determine viability of a fetus after 28 weeks. So after 28 weeks, it's a viable fetus. Before 28 weeks is pre-viability. So anything that happens to a fetus below 28 weeks is called an abortion or a miscarriage. After 28 weeks, there is viability. So APH is bleeding after 28 weeks. So some of the causes of APH, the most common is abruptio placenta, which we'll look at in another video, 0.5%, and then previa, 0.3%. We also have cervical and vaginal trauma, coagulopathy, vasa previa, circumvallate and circummarginate placenta. So vasa previa is bleeding from fetal blood vessels, as opposed to other causes where the bleeding is maternal. In vasa previa, the bleeding is fetal. So what it means that the fetal blood vessels abnormally run across the opening of the cervix, the cervical os. You see, as the internal os is labeled, that's where the cervix is. So the blood vessels run across the cervix and into the amniotic membrane. So when the mother is delivering and the cervix is dilating and the amniotic membrane rupture, the fetal blood vessels rupture together. So there's a lot of fetal bleeding. Circumvallate and circummarginate placenta are just abnormal placentations. The shape of the placenta, the colon is too short. The colon is the fetal side, so the placenta has to fold on itself. Just have a look at the different. There is the circumvallate and the circummarginate placenta. They are mostly similar except for the shape and the folding. So now we look specifically at placenta previa. So in placenta previa, it's a condition where the placenta is partially or totally located in the lower uterine segment. Usually, placenta should be located in the fundus, which is the top of the uterus. But in previa, the placenta attaches in the lower part of the uterus, which is problematic because that's where the baby is supposed to come out from. So if you have all placenta there, it can lead to complications and a lot of bleeding. So risk factors of previa, previous history of previa, and C-section are one of the most common causes of placenta previa. We have smoking, because basically why the placenta attaches the lower uterine segment, which means that the other parts of the uterus are not as healthy or the blood vessel supply is not as much. So the placenta needs to spread out to increase its surface area. So things like smoking, which clogs up your blood vessels, make it harder for the placenta to get enough nutrients and oxygen from the existing uterine vessels. So it has to spread out to increase its surface area. So by spreading out, there's a high likelihood it will go to the lower uterine segment. Same concept for multiple pregnancy, which means that you're carrying either twins or triplets or quadruplets. So the placenta is already big, and again, it needs, for it to sustain the many fetuses, it needs more blood and oxygen, so it will spread out. Bilobate placenta, which means that the placenta is divided into two. One of them is likely to be in the lower uterine segment. Sexcentural placenta, again, the placenta is two, but one is just a small accessory lobe. And the accessory lobe usually attaches to the lower uterine segment. Curettage, which is DNC, which means you have to, this is one of the types of abortions. So it's basically you have to scrape off the products of conception from the uterus. So that scraping off can cause fibrosis. So the placenta usually avoid the fibrous areas and you will go to healthier areas. Grand multiparity, which means many previous pregnancies, usually more than 4. Excuse me. So some of the clinical manifestations of previa. So there is vaginal bleeding, which is bright red, as opposed to abruptio, which will be dark. Because in previa, it's just separation. Because the placenta is in the lower part of the cervix, when the mother goes into labor, there will be cervical changes. One of them is dilatation and effacement. Effacement means shortening. So when imagine the placenta is just there and the cervix is dilating and they're shortening, so there'll be a bit of placental separation from the walls of the cervix, which will cause fresh bleeding. The bleeding will be painless, unlike abruptio, because in abruptio it's kind of violent. The placenta literally separates prematurely from the uterus, from the top of the uterus wall. So that's painful. But in previa it's painless and it's causeless. There is no history of trauma. There is a warning hemorrhage, which means spotting a few weeks or a month earlier than the actual PV bleeding. We have recurrent bleeding of fresh blood, and fetal sounds, heart sounds, are usually heard, unlike in abruptio, where fetal heart sounds may be diminished. And then the fundal height is equal to the period of gestation, unlike again in abruptio, where the fundal height may be more than the period of gestation. Meaning, if by dates and by ultrasound she's 34 weeks, when you palpate the fundal height, if it's previa, the fundal height will be at 34 weeks. However, if it's abruptio, it might be at 36, 38 weeks. Because in abruptio, there's a lot of blood accumulation around the uterus walls, increasing the height of the fundus. So classification, this is Brown's classification. It's type 1 to type 4. So type 1 is the rightmost and type 4 is the leftmost. So in type 1, it's low-lying placenta, which means that the placenta is within 2 centimeters of the cervical os. Type 2 is marginal, which means that the margin of the placenta is opposed to the margin of the cervical os, so they're touching each other. Type 3 means the placenta has partially covered the os, and type 4 it has completely covered the os. So this is Brown's classification. And then now we'll look at placenta previa in terms of degrees, and its degrees which will affect management. So investigations, again, the common ones, full blood count to know because you are bleeding, so we need to know if there's anemia by looking at the level of hemoglobin. CTG is cardiotocography, which means that there's a graph of fetal heart rate and uterine contractions. So basically when the uterus contracts, the fetal heart rate reacts to the contraction. So that's the stress test, and then we have the NST, which is the non-stress test, which again you look at fetal heart sounds but without contractions. So it's one of the best indicators of fetal distress. And then transvaginal ultrasound, which is diagnostic. It will show where the placenta is located. Usually done in the third trimester, usually after 37 weeks, because that's when the location of the placenta is now permanent. Now degrees of previa. Again, let me go back. So type 1, remember type 1 was the low-lying one. So type 1 and type 2A is minor degree. Now type 2A, remember type 2 was the marginal one. Margin of the placenta and the margin of the internal os are touching each other. So type 1A is anterior. The placenta is marginal, but it's anterior. It's towards the abdomen of the mother. Type 2B is posterior. The placenta is towards the back of the mother. So type 1 and type 2A are minor degree placenta previas. And then type 2B, type 3, which is the partial, and type 4, which is the complete, are major degrees placenta previa. So a little bit on the type 2 posterior. As you can see in the diagram, the placenta is towards the back of the mother. So the reason this is problematic is when there is contractions, the fetal head will compress the placenta against the sacral promontoid, which is that bump in the vertebra you can see at the back of the mother. So when the placenta is compressed, the blood supply to the fetus reduces. So this will produce the stallworthy sign, which means that uterine contractions lead to decrease in fetal heart rate, which normalizes immediately the contraction stop. So the decrease in fetal heart rate is because of the compression of the placenta between the fetal head and the sacral promontory. Excuse me. Now we look at management. So management is simple, divided into after 37 weeks and below 37 weeks. So if it's after 37 weeks, you look at if there is active bleeding, you just take the patient for C-section, emergency C-section, and you deliver the baby. However, if there is no active bleeding, the minor degree placenta previa, which is type 1 and type 2 anterior, you can attempt vaginal delivery. Now type 2 posterior, type 3 and type 4, which are the major degrees of placenta previa, you have to deliver through C-section because of the compromised location of the placenta. So basically, after 37 weeks, two things you look at. Either it's minor or major. Minor degree, you can try vaginal delivery. Major degree, C-section. Now, if the baby is below 37 weeks, which means that probably the lungs are not that mature, and there's a risk of prematurity after delivery. So in previa, we have that option of conservative management. As we'll see in abruptio, there is no option of conservative management. So in previa, if there is bleeding, you can attempt conservative management first. It's called the McAfee-Johnson regimen, the conservative management. So uteroplacental resuscitation means that you just give fluids. Give fluids trying to make sure that the placenta is getting enough blood, the fetus is getting enough blood, and usually with IV fluids, running for 1 or 2 days, the bleeding will calm down and you have a chance to progress the pregnancy into term at least after 37 weeks. So you give fluids, you give corticosteroids, which will help in fetal lung maturity. If there is labor, if you detect contraction, you can give tocolysis, which will reduce uterine contraction. And if the mother is Rh negative, so if a blood group is negative, any negative, O negative, A negative, you can give the anti-D to prevent isoimmunization. However, despite the conservative management, there is still persistent bleeding. You have no choice but to take off a C-section. Thank you.